Good afternoon, everyone, and welcome to today's webinar, The Role of Pharmacies in HIV Prevention. This is an important discussion as we explore the expanding role of pharmacies in HIV prevention and their partnership with physicians, particularly in serving Hispanic and Latino communities. CME credits will be offered for physicians, pharmacists, and pharmacy technicians, free for members and $25 for non-members. Additional details on how to claim your credits will be sent via an email blast within 1 week following the webinar. But I'd like to introduce myself, and good afternoon, everyone. My name is AJ Obake. I'm a board member of the National Hispanic Pharmacists Association and Health and Wellness Director in the New Jersey area. I'm excited to moderate today's webinar and help facilitate a meaningful discussion on this important topic. And I'd like to thank everyone for joining us. And I'd like to mention a few housekeeping items. This webinar is being recorded and will be shared via NHMA's YouTube channel and website. Please submit questions through the Q&A box at any time, and we'll have time at the live Q&A at the end. And so I'd like to give a brief introduction about NHMA, the National Hispanic Medical Association. For those who may be new to NHMA, we're a nonprofit organization that represents over 50,000 licensed Hispanic physicians in the United States. Our mission is to empower Hispanic and other underrepresented healthcare professionals to improve the health of Hispanic and underserved communities. We advance this mission through leadership development, health policy advocacy, education, and strategic partnerships with federal agencies, academic institutions, and community-based organizations across the country. And today, we're honored to be joined by two incredible speakers who bring extensive experience as a physician and a pharmacist. You'll hear from Dr. Mark Allen Derry, infectious disease physician and medical director at Access Health Louisiana, and Dr. Ashton Cobb, clinical pharmacist at the Center for Living Well, Epcot. They will share how physicians and pharmacists can work together in HIV prevention, and particularly within Spanish-speaking communities. So our first speaker is Dr. Derry, infectious disease physician and medical director at the Access Health Louisiana. Dr. Derry's presentation will discuss the current landscape of HIV prevention in Latino Hispanic communities, emphasizing the clinical importance of PrEP and PEP, while highlighting the importance of interprofessional collaboration between physicians and pharmacists. I'll go ahead and give it to Dr. Mark Allen Derry.
Great. Thank you so much, AJ. I appreciate it. And if we could just go ahead and get the slide deck started here. Thank you. So today, going to be talking about the role of pharmacies in HIV prevention. Next slide, please. With a focus on prevention in the Latino Hispanic communities and really focusing on the clinical role of PrEP, PEP, and importantly, the physician-pharmacist interprofessional collaboration, with our objectives being essentially to understand the disproportionate HIV burden in the Latino Hispanic communities and try to understand why that is, review clinical applications of PrEP and PEP, identify the barriers to care access, again, especially as it relates to the Latino community, recognize strategies for culturally appropriate service delivery, which I think is important in this setting. And then lastly, and really what the entirety of this lecture or this discussion is about is essentially to explore the physician-pharmacist collaboration models that exist. And I try to give an example or two of those, and we'll probably get to that in about 12 minutes. So next slide, please. So when we talk about the HIV epidemic in context, we look specifically at the Latino community. In 2019, the Latino community essentially represents 18% of the total U.S. population, but account for 29% of new HIV diagnoses. I like round numbers. So let's just say 20% of the total U.S. population is Latino, whereas they account for 30% of new diagnoses. So certainly there's a disparity there. So when you look at Latino men who have sex with men and transgender women, Latino transgender women, these are the communities that are particularly affected, with Latino transgender women showing HIV prevalence rates of 42%, and that's a tremendous number, and 62% amongst Black transgender women. So you could see transgender as being a person of trans experience is a risk factor when you look at it from the lens of a Latino person of trans experience or a Black transgender individual as well. You see that those rates are significantly increased, particularly for women. The ending the HIV epidemic initiatives, which were really quite, were very progressive, if you will. Those aims were to reduce new infections by 90% by 2030. They were very lofty goals, but the money was there to actually make it happen. Certainly, there was a lot of those resources were made available in New Orleans. Certainly, the medical system that I work within, we were able to access those monies and do some really interesting and innovative programming. Unfortunately, the fiscal year 2026 budget bill essentially completely cancels the End the HIV Epidemic program, and I that has not been passed yet. And the intricacies of that go back and forth. But I just wanted to let you guys know that the EHE may go away in this FY26 fiscal budget bill. Next slide, please. So when we talk about PrEP, PrEP stands for pre-exposure prophylaxis. We're going to talk about PrEP and then PEP, right? So PrEP is, if you use the example of birth control pill, you take a birth control pill, for example, to prevent a potential upcoming exposure, and then you would use Plan B as a so-called emergency contraception that would occur after an exposure happens. So PrEP and PEP are the same thing. PrEP is medicine that you take before a potential HIV exposure, and PEP, post-exposure prophylaxis, is taken after an exposure occurs. So when we talk about PrEP, we're really talking about four new formulations. The first is the first one on top. I'm gonna just read them off. Which is, the first one is tenofovir and emtricitabine, also known as Truvada. Was the first one that offers really excellent, I think upwards to all of these actually offer 99 to 100% protection when taken appropriately. This is the workhorse. This is the one that's most commonly prescribed. It's also generic. The second one is tenofovir with it's tenofovir alafenamide with emtricitabine, also called Descovy, also taken daily, also offers excellent protection. Then we're at the area now where we can have injectables. There's one that's injectable every 2 months and one every 6 months. And you can see this starting to get pushed further and further. Hopefully, maybe we see one. And I know that the makers of lenacapavir, the one that's for every 6 months, are already starting to explore once every year. And once we start getting to something like that, this is not quite a vaccine because it doesn't stimulate an immunity like a vaccine does. But we do take, flu vaccines every year, and maybe we're getting to a point where we're taking COVID vaccines every year. It may be that perhaps we could get a shot that would protect us for HIV for upwards to a year. Right now, we're at 6 months, and that's what's FDA approved. But ideally, if we can continue to push that, we can really start to see how we can get to an HIV-free world just with medications through the use of PrEP. Next slide, please. So post-exposure prophylaxis, as I mentioned again, occurs after a potential exposure. Most of the times that I see it, just being a doctor here in New Orleans, I'll get phone calls or we get emergency clinic visits from, anywhere from a condom broke to somebody who comes to New Orleans and and maybe they enjoy New Orleans a little too much and wake up in the morning recognizing that their better angels are speaking to them to get some protection. And so post-exposure prophylaxis, which, as I say here, it should be considered for youth and adults after a potential exposure, or in the cases that we see, unclear of who the exposure may have been the night before. It also indicated for unsafe needle use or potentially sexually violence. What's key here is that it should be taken within 72 hours of exposure. It is a 28-day antiretroviral regimen, so it's an actual regimen, whereas PrEP is one part of a regimen. The PEP is actually you're taking a full HIV regimen. So three meds as opposed to the two, and it requires a physician to or a clinician to do some testing and some follow up as well, and it could be considered as a bridge to PrEP for ongoing risk. Next slide, please. So when we're looking at in terms of access and awareness and referrals, only 27% of Latino people tested at CDC-funded sites were actually aware of PrEP compared to higher rates amongst non-Hispanic or Latino white people. Amongst those that were eligible, only 22% received PrEP referrals in 2019, and estimated only 10% who could benefit from PrEP. 10% of Latino women who could benefit from PrEP receive prescriptions with significantly lower rates. I'm sorry, 10% of women who could benefit from PrEP prescriptions and significantly lower rates amongst Hispanic women. And the CDC estimates PrEP coverage at just about 13.8% for Hispanic or Latino people versus 60% versus white. So this is something, again, an area for us to really focus in on and making sure that these social determinants of health and these disparities cease to exist in whatever way possible. Next slide, please. So when we're looking at multi-level barriers, so what are the barriers to PrEP as they exist? Well, they exist on the individual level, the healthcare level, and then the structural level. So on the individual level, as we mentioned a moment ago, there can be lower PrEP knowledge and HIV risk perception, at which there is a number of things such as intersecting stigma that can involve HIV, sexual orientation and immigration status, or just plain old medical mistrust. On the healthcare system level, there's limited cultural and linguistically appropriate services, provider gaps, and what's referred to as the purview paradox, which is this idea of somebody may be able to write a prescription but just doesn't know how to do so. Or it's also folks like me who do know how to write these prescriptions, but all of my patients already have HIV. And so me finding individuals that do have that, who do need PrEP, I'm unable to access them as a population or as a group of individuals just because the folks that come to me already have HIV. And of course, insurance and cost barriers are always a problem. We live in America. Lastly, it's the structural level, including geographic and access limitations. This is where telemedicine has become very, very helpful, something that I really am quite a big believer in. Because of immigration-related fears, a lot of my work now is strictly through telemedicine because of, again, the first 2 points up there. And then lastly, unfortunately, we, again, live in America where systemic racism and health inequities, as the previous slides show. Next slide, please. So, what happens when we use culturally tailored interventions? Do they help? Well, yes, fortunately they do. There was a number of studies here. There are two here that I'm highlighting. The PrEP-Rate social marketing campaign in Chicago showed that campaign exposure was associated with a 5-fold increase in PrEP awareness and 69% increase in PrEP uptake in the Latino community. The CEPA plus PrEP intervention demonstrated a feasibility and accessibility amongst Hispanic women, with 70% reporting condomless sex, but zero baseline PrEP knowledge prior to the intervention. So it is possible to create culturally tailored interventions. And I think that is best left to each healthcare system as they know their communities best. Next slide, please. So, what happens when we have Hispanic or Latino oriented clinical services? So, dedicated services, specifically as it relates to PrEP, significantly improve outcomes. In the Thrive project, sites with Latino oriented clinical services showed a 2 times higher PrEP linkage for both MSM and transgender women, a 1.6 to 2.1 times higher PrEP prescription rates, and 87% Latino MSM and 85% transgender women receiving HIV screening. Next slide, please. So it is possible to do, which is very encouraging. What about expanding access through non-traditional settings? This is very, very important, especially in a place where I am. I'm sure very much where you are as well. But community-based organizations work, trusted hubs for comprehensive sexual health services, which is what we provide, teleprep, and just telemedicine overcomes transportation and scheduling barriers, as well as just what we're seeing in New Orleans, what we have seen just in the past couple months, and what we're likely to start seeing again. Our fears for going out, certainly being seen by their physicians or their clinicians. Certainly, telemedicine has been just tremendous. Mobile clinics are helpful so we can actually meet the community as to where they are. Something that I think is incredibly important and I support tremendously is pharmacists prescribe PrEP, which again is just meeting people where they are so that this way PrEP is available, it's convenient and community based. And then emergency departments is not ideal, but of course will ultimately reach individuals who are not engaged in regular care. Next slide, please. And I'm called by my emergency department all the time to try to get folks started on PrEP, just by the ER docs as well. So what about that collaboration model we talked about a moment ago, this physician pharmacist collaboration model? Pharmacists can prescribe PrEP through collaborative practice agreements or state legislation offering convenient community based access. So I think moving forward, I think we are seeing some versions of this in California, certainly with birth control, and I would love to see it in areas where we can do it with PrEP as well. The interprofessional model addresses that so-called purview paradox, which you talked about a moment ago, where as an HIV specialist, I see very few folks who are not HIV positive, but whereas primary care providers or other folks, like we said, pharmacists or through the ER can actually provide some of that PrEP or PEP. So I think collaborations are important. So again, pharmacists initiated PrEP screening and prescribing, physician oversight for complex cases, shared protocols for baseline as well as for follow-up testing, and coordinated adherence for support and STI screening. I think there you have the ingredients and the wherewithal to really create programming that will work in any community. Next slide, please. I think culturally appropriate service delivery is important. We talked about that at the very top of this talk. I think that some of the essential strategies include linguistically appropriate services. So this way, Spanish language materials and bilingual staff is important. I think culturally tailored messaging is important, like what we saw in the community-driven campaigns like Preparate. Stigma reduction is always important, especially when it comes around issues of HIV and when we're talking about issues regarding sexual intimacy, trust building, and then just normalizing PrEP discussions, integrating them into routine sexual health conversations as opposed to risk-based screening. So in the end, routine, non-judgmental sexual history taking for all patients ultimately facilitate risk assessment and then ultimately PrEP discussions. Next slide, please. I think adherence is probably one of the most important things because it is critical for success. So strong adherence is important. Unfortunately, in studies shows that African American community and young people show lower adherence rates. So we need to target specific interventions for specific communities. And I think components of effective adherence support focus on trust and open communication, need to talk about, actually, in the context of what we're talking about, is PrEP mechanism and importance, reminder systems for medication taking, proactive adverse effect management, regular follow-up and encouragement, and then also always, always, always is addressing social and structural barriers. Next slide, please. I think for action steps, I think implementing routine sexual and drug use history for all patients in a non-judgmental manner, educating all sexually active patients about HIV prevention options, as well as other STI prevention options as well, establishing PrEP referral pathways, partnering with pharmacists for collaborative PrEP delivery, and utilizing resources that are available. I think from a system level, advocacy supporting zero out of pocket costs for PrEP is so important, because just even a little bit of co-pays really do push people away. Advocating for culturally, linguistically appropriate services and addressing structural barriers. Next slide, which I think is the last slide. I think key takeaways here, and really the things that I really want to kind of really impart upon all of us as we start this conversation, is that Latino communities face disproportionate HIV burdens. As we talked about, 29% of new diagnoses. PrEP is highly effective, upwards of 99 to 100% adherence, but unfortunately very underutilized in the Latino community. Multiple barriers exist at the individual healthcare and structural levels, and they require multi-level interventions. Culturally tailored and community-driven interventions do work, as demonstrated by a fivefold increase in awareness. It's so important for physicians and pharmacists to collaborate with non-traditional settings. And then routine, non-judgmental screening and comprehensive adherence support are essential. Is there one more slide, or I think is that the last slide? I thought maybe there's one more slide after that, or that may be it. So here we go. So the path to ending the HIV epidemic require addressing persistent disparities through culturally appropriate, accessible, and collaborative care delivery. I really truly live my life by that. And I think it's such an important thing for us to focus on. And I think in this audience that I'm speaking to, I think that probably resonates quite well. So thank you very much for having me. Thank you to the NHPA for allowing me to have these few moments to speak during this very critical conversation.
And thank you so much, Dr. Mark Allanderi, for your insightful presentation. We truly appreciate your expertise and passion surrounding HIV prevention and collaboration. And I'd like to introduce our next speaker, Dr. Cobb, clinical pharmacist at Center for Living Well, Epcot. Will discuss the expanding role of pharmacies in HIV prevention, including the initiation of PrEP and PEP, adherence support, and patient counseling, while addressing the best practices for serving Spanish-speaking patients.
Good afternoon. Thank you for having me today. Let's go ahead and dive deep into this topic. So I'm going to talk about expanding the role of community pharmacies in PrEP and PEP adherence and culturally responsive care for Latino and Hispanic communities. Next slide. So these are my disclosures. Next slide. This is just highlights of my career. We can just kind of skip over this. So the objective. So after this presentation, you'll be able to understand why community pharmacies matter in HIV prevention. We'll talk about pharmacist-led PrEP and PEP initiation, like what it looks like. We'll talk about adherence support and ongoing patient engagement, patient counseling that builds trust and reduces stigma, best practices for serving Spanish-speaking patients, and partnering with physicians and community organizations as well. Next slide. So community pharmacies and HIV prevention, why does it matter? Next slide. So pharmacies are uniquely positioned to normalize and scale HIV prevention. Just think about it. They're everywhere, and most importantly, they're easily accessed by underserved, rural, and minority populations. They are a trusted, accessible healthcare touchpoint with a neighborhood presence, and most times have extended hours outside of most medical practices, besides urgent care, maybe hospitals. Because pharmacies are generally not associated with the specific high stigma health conditions, they serve as a more discreet, maybe even a welcoming environment compared to traditional, maybe sexual health clinics. Um, as we've already kind of mentioned and discussed before, Hispanic and Latino people in the U.S. are disproportionately affected by HIV. Um, they account for almost 20% of the population, but make up, almost, 35% of, new HIV infections. Um, a lot of this is driven by social determinants of health, including poverty, stigma, limited health access, immigration concerns, and cultural/language gaps. Next slide. So pharmacist-led PrEP and PEP initiation, what does it look like? So some patients might inform us of their risk factors voluntarily, but it's important to conduct a thorough risk assessment, including a past medical history, complete medication review, high risk acquisition, high risk HIV acquisition, drug or alcohol abuse utilization, and resources such education should be provided to aid in reducing HIV acquisition. So, condom use, regular testing and screening, harm reduction for injection drug users. So, when we're conducting these interviews, we need to be aware of cultural sensitivities. The most important thing, using empathy and asking open-ended questions. Honestly speaking, the only person who is not at risk for HIV acquisition is the one that is sexually abstinent. So if you're engaged in any type of sexual activity, you're at risk, and your risk increases depending on how you have sex, the use or no use of barriers, frequency, number of partners, and your partner's sexual history status. And this pie graph really just kind of highlights, just some of those risks, and having a few or multiple of these just increases that. Next slide. So as we've already kind of mentioned, PrEP initiation, really, identification and risk assessment, doing baseline testing and workflow. And in some models, we have same day PrEP initiation after you might do, rapid HIV tests and things of that nature. We also have to, navigate through insurance navigation. And maybe if that person doesn't have insurance, maybe even, utilizing patient assistance programs. PEP is a little bit more time sensitive, using rapid assessment and referral coordination and short-term dispensing with follow-up and handoff. The most important thing with either of these two workflows is having a standardized protocol. So whether it's a CPA, which has clear escalation pathways to physicians or clinics if needed to be escalated in a different manner. Next slide. So let's talk about adherence support. So some good pharmacy-based adherence strategies. Let's say you have a patient who is using oral PrEP. So doing, some type of medication synchronization, refill reminders, whether they're app-based or text-based. And then even when they're coming to pick up, quick consults of just adherence check-ins at that point, side effect management, things of that nature. Also looking at, whether or not, they're picking up their refills on time. That can lead or kind of indicate, what kind of barriers they might be having to adherence to, the cost of the medication, affordability. And that's where we can kind of look at, if this is, someone who has maybe a commercial insurance plan, if they're using a branded product, maybe using a copay card, or maybe even looking at patient assistance programs. And during these points, you can address real life barriers, work schedules, transportation, fear of disclosure at home. And the main point of all of this is the outcome focus, just to reduce discontinuation of PrEP, and also breaking down any barriers of misinformation or stigma. Next slide. So let's talk about building trust when doing patient counseling and reducing stigma. So pro counseling tip. Trust is really built in small moments. tone and body language matter. It is just as important as the content that you're going to provide or the information that you're going to give. We have to normalize PrEP and PEP as preventative care. So just like how it's already been mentioned, like vaccines or birth control or normal screenings for diabetes or cardiovascular disease. This is the same. Um, it's just important that when we do this, we use sex positive and non-judgmental language, avoid assumptions about sexual orientation or behavior, and we also must consider privacy and respect for our clients' confidentiality. So secluded consultation areas, if we have that. Um, Also thinking about the noise or the volume that maybe we're using or discussing, and maybe even thinking about discrete labeling and packaging. So I threw this picture in here on this slide because I know that we're all aware of oral therapies for PrEP that have been around for 10 plus years, and injectable therapies have been around for the last 4 years and change. And I included this picture of just potential future therapies as far as like different formulations as a way for individuals who, for example, we know that a lot of Hispanic and Latino communities, sometimes they live in multiple intergenerational households, and maybe they want a way to be able to maybe keep their business private amongst family members. And let's say if they have a bottle of, Truvada, or it's generic, or Descovy, it's easy for someone to easily just pick up a bottle, Google it, figure out what's going on. But with the injectable therapies that are out right now, more discreet, something that you're not actually taking every day and keeping at home, something that maybe you're going to a clinic to get administered, maybe even a pharmacy, or if maybe you had an implantable device that was delivering some type of drug, or maybe even an intravaginal ring. But that's just as important as well too. Next slide. So let's talk about best practices serving Spanish-speaking patients. So language access strategies. It's important to ask clients their language preference upfront. And if possible, not to rely on family members to interpret unless indicated by the client. Having bilingual staff members, pharmacists or technicians, or using a certified interpreter services, whether they're in person or telephonic, is paramount as well too. And using Spanish educational materials written at appropriate literacy levels, which I usually recommend at an elementary level for comprehension. Those are paramount. I personally don't speak Spanish, but for my Spanish speaking clients, either I have a staff member who might speak Spanish and is willing to interpret if that patient wants that service, or most times I'm using a certified language line. Cultural humility. It's also important to understand family dynamics, cultural norms, mistrust, and immigration related fears, and just using relevant phrasing to avoid literal translations. The most important thing with any of these strategies is that we need to know how to lead with empathy. This allows a client to bring their full authentic selves and encourages questions without shame. Next slide. So let's talk about collaboration. So partnering with physicians and community organizations. What does that look like? So any of these models really help to reduce provider burden, increase PrEP and PEP uptake and retention, and build a stronger continuity of care. There are some regulatory barriers. While in 17 plus US states, there's already authorized pharmacist provided PrEP and PEP, there are significant high prevalence areas like in the South, which are still lacking these legislative changes requiring further advocacy. So you could either have a standard protocol, where you're doing this testing and then you're either providing treatment and then further escalation is needed, whether, there actually is HIV seroconversion or whether, someone tests positive for STI, you're actually providing a warm handoff either to, a primary care provider or the provider who you're collaborating with the standard protocol, or having just a collaborative practice agreement as well too, which is very similar. In my current practice right now, I use a collaborative practice agreement. So I have patients which I do a full assessment and workup, order labs, provide PrEP or PEP, and then if anything it's further escalated, whether someone tests positive for STI, someone tests positive or seroconverts for HIV, then I'm actually referring back to that provider, with those details and then moving forward with that. Next slide. So the key takeaways and call to action. So the main thing is overcoming inequity, investing in training, workflows, and partnerships to integrate PrEP and PEP into pharmacies can allow healthcare providers better reach populations not currently engaged in traditional healthcare, improving equity in HIV prevention. So community pharmacies, they can lead these efforts. We can initiate PrEP and PEP, provide that adherence support, provide that counseling in the pharmacy setting. Having that language access and culture responsive are essential. It's not optional at all, because if you don't have it, then you're not going to get that engagement. And then, of course, if we collaborate with other healthcare providers and physicians, it just strengthens the whole healthcare unit as a whole. Next slide. Those are my references, and that's it. Does anybody have any questions?
Thank you so much, Dr. Cobb, for sharing your insights on the importance of role pharmacies play in HIV prevention. We truly appreciate your expertise and ability to address best practice for serving Spanish-speaking patients. And I'd like to thank both of our speakers for such an insightful and thought-provoking presentations. We're now going to move into the short panel discussion and take questions from the audience. Please continue to submit the questions through the Q&A box if you have not already done so. Looking into the Q&A, I do have some questions, and this is for either Dr. Cobb or Dr. Derry, or if you both want, to give some input, some insight. And so, how can both providers and pharmacists ensure that HIV prevention services are culturally sensitive and accessible?
Dr. Cobb, I'll let you take a crack at it.
Yeah, sure. I would say that one, being able to provide a service either, at a pharmacy in collaboration, with physician or provider, that right there just makes it accessible. Most people live within, maybe 5 to 10 minutes from a pharmacy. And if you're able to normalize discussions about sexual health as, just as a preventative measure, and not make it kind of like, special, then that way you're able to really you're really just you're really engaging people in care. And as it's specific to Hispanic and Latino communities, I think that if you have staff members that are bilingual, if you have um, patient materials that are provided in Spanish and in English to make those individuals feel comfortable, then you're going to get the level of engagement of those that, we might not have reached before, and including them into healthcare. So I think that's, one of the best ways to, bring people within the fold and whatnot.
Yeah, and I think you bring a good point, right? As someone that speaks the same language and intentional, about providing interpretive services. But and Dr. Derry, you mentioned something important, that some of the barriers is geographic. We think usually very metropolitan areas, right? But you did mention some geographic barriers. I personally have supported pharmacies that may be in a rural, very agricultural area that may be highly Hispanic and Latino, where it's sometimes hard to staff with those skill sets. And so, Dr. Derry, what have you seen on both on the provider and, in collaborating with the pharmacy and maybe having to collaborate with the community pharmacy to get some of those services and culturally sensitive and accessibility in those areas?
Yeah, I too, after I completed my residency training, I lived on the Navajo reservation for 4 years, and that was extremely, extremely rural. Especially that was like almost, that was 25 plus years ago. So, and I know that some of those rural areas obviously still exist now. And so I think it's important. I mean, I think Dr. Cobb had a couple of number of great points. I think making sure that services are available in languages that can, that are commiserate with the community they're trying to serve. I have now taken to having just on my phone, having a service, just because living in New Orleans, we have so many different languages that are spoken. I just keep an app on my phone that's provided by our healthcare system. And just today, just using American Sign Language and just having a video on the phone and just having a person who was able to sign with the patient who was in front of me and helping me to kind of interact with her in something that's appropriate. Again, New Orleans small, but we have a number of different cultures and languages that we serve here. But the important thing here is, I think, two important points is I just can't kind of overestimate the importance of telemedicine and telehealth. For me, that has been such a game changer in being able to deliver. One of the personal statistics and achievements that I've made personally, especially during COVID, was that I have treated, I think last that was kind of, a number that was kind of floated by me by our administrators was something like between 400 to 500 people living with hepatitis C, and I've been able to cure them of their hepatitis C. And a majority of them, I've never actually seen them, that they were just done telephonically. So where there is a will, because the state of Louisiana had a very, very specific goal to try to eradicate hepatitis C. We weren't necessarily successful with it, but certainly some of the creative models that we use to try to get to zero hepatitis C in the state of Louisiana have been successful because they were able to change rules that made it possible for us, for me, people like myself, to be able to get to individuals who are hepatitis C positive and get them cured from hepatitis C. And I think the same thing could be done with HIV and with prevention of HIV through PrEP. And I think one of the most important places, like you were saying, AJ, is through the use of collaborative models with physicians and pharmacists. We're seeing models like this happen in California, and I think that where there's a will, there's a way. There was a will for Dr. Rebecca Gee, who is the health commissioner of the state, who set up this so-called Netflix model that allowed us to have unlimited access to hepatitis C medicines, no pre-authorizations, no nothing. If we write it, it gets immediately filled. It was one medication, but still, it cured 99% of all hepatitis C various viruses. So there was the will to do it. We eliminated the regulations, and we were able to do it. I think that the will needs to be there as a collective HIV and HIV preventative community. I think that having these collaborations between physicians and pharmacists, so that we could get to this HIV-free world, I think it's available. We can do it, and certainly with these injectables, and certainly as these injectables get to up to 6 months, and if we can get beyond 6 months to 1 year, if you can get that at a pharmacy. I go to the pharmacy to get my shingles, my RSV, my COVID, my influenza. If we can now also be able to offer PrEP through injections that can be done at a pharmacy, I think we're really getting to places that we could get to an HIV-free generation or a free world.
Amazing. All right, great insight, and thank you for sharing, on those compliments to the hepatitis C. And so one thing you definitely addressed the accessibility here, both you, Dr. Cobb, and Dr. Derry. And one thing to mention is, how do we identify those patients? And so, my question, follow-up question to Dr. Cobb. Um, so how can community pharmacists initiate conversations about PrEP or PEP with Spanish-speaking patients? So how do we kind of identify those patients in need in a community setting? And then I'll have a follow-up for Dr. Derry. Dr. Derry, I know you did share about your emergency room referring patients, but how do we identify as physicians? So I'll start with Dr. Cobb. In the community setting, pharmacy setting, how do you get engaged those and identify those patients that may be in need?
Yeah, yeah. It's really just normalizing, sexual health as just any type of general health and wellness screening. So, you know, like before what we mentioned, you know, we use vaccines to, prevent flu, COVID, other communicable diseases. We use birth control to, maybe prevent, pregnancy. So we're talking about preventing HIV, whether you're doing it, through oral formulation, injectable, and whatnot. And it's really just using respect, um, and and just normalizing the conversation. And at the end of the day, when you normalize the conversation and you're empathetic, and then even using moments like pause moments in your conversations when you start to discuss sexual health, because that gives the other person, it's like almost a level of consent to them. So like um, it's very powerful when you just pause and just say just let them kind of reflect on what you're kind of discussing, and it's like I'm giving you the consent to say, hey, let's discuss your sexual health practices, because we know that we all do it, whether it, with another person, or different ways that we do it. It's just about identifying our risk overall, and if we have, one or more or multiple different risk factors, just figuring out a way that, we're all being safe, and we're all making sure that we're preventing, HIV acquisition and getting to, an HIV free world. So
Definitely. Thank you, Dr. Cobb. And so, Dr. Derry, how can physicians identify patients who might benefit most from HIV prevention strategies but not currently engaged in care? So, like, if the emergency room is not recommending, how do you ensure you might identify a patient that may benefit from HIV prevention strategies?
So, I mean, I think Dr. Cobb mentioned a few of them, like the routine, sexual and or drug histories that are, the standard part of every primary care visit, and certainly, regardless of any stated reason for visit, and in the ER, if it's something that is a function of whatever, or is contextually whatever their visit is there for. But I think EMRs can help flag patients with risk indicators as well, such as previously treated or seen for STIs or injection drug use. Um, somebody who has known multiple partners or partners with unknown status. So clinicians can, essentially proactively discuss testing and PrEP, even if the patient doesn't bring it up. I think, going back to the ED collaboration with emergency departments, um, I mean, even urgent care centers and pharmacies, they'll service individuals who will frequently seek out acute services, but lack a regular source of care. I think physicians can also rely on partnerships with community organizations and outreach teams to identify people at risk who are not seen in clinic, but create, and create low barrier entry points such as walk-in PrEP visits, telehealth, and rapid start services. So using a non-judgmental, trauma-informed approach and explicitly addressing stigma, immigration concerns, and confidentiality, I think can really help patients feel safe enough to disclose risk behaviors and ultimately accept these prevention services that we offer and are, passionate about.
Great. Thank you, Dr. Derry. And then we have a someone chatted in the Q&A box from Steve, question from Steve. Once I have committed to providing PrEP in my community pharmacy and have completed all the required steps to do so legally, now I'm ready. What is the first thing I should do to build that practice?
I'll take that question. So, first of all, thank you for that question. That was excellent. I think the main thing you should do is just seek out in your community, um, who else is doing any type of sexual health services, or seeking in the community, who's the nearest or closest primary care provider, and then building a collaboration with them. So, for example, if you're gonna build like a standard protocol, so like I know some pharmacies have protocols for immunizations and test and treat programs and things of that nature. So let's say you want to build a protocol for PrEP and PEP, reaching out to that provider, maybe that you already have, a protocol for maybe immunization or test and treat, and then adding this as a service. So therefore, that you're providing a service at your pharmacy and you're giving these treatments, and then if there's any need for escalation, that you're able to refer to this provider for whether it's STI management, or whether if someone actually has seroconverted. So yeah, that's really the main thing, just understanding who the players are in your area, who you can collaborate with, who's willing to collaborate, and then really just providing service. So
Okay, great. Great question. Great answer. Let's see if we have any more questions. We have a couple minutes left. I do have one for Dr. Derry. In your experience, what are some successful examples of physician-pharmacist collaboration that have improved patient outcomes in HIV prevention?
So, I think that when we're talking about successful physician pharmacist collaboration, these rely on formal agreements that allow pharmacists to initiate and manage PrEP while maintaining close communications with physicians. For example, collaborative practice models can exist in HIV clinics and community pharmacies. And these have actually shown that pharmacists conduct risk assessments, arrange HIV STI testing, prescribe PrEP, manage refills, follow adherence, and it works great. And this allows somebody like myself to handle some of the more complex medical issues as well. One program that was linking in academic HIV clinic with community and clinic-based pharmacies. Nearly half of the participants there chose the community pharmacy for follow-up. And then at about 6 months, more than half of them actually were still returning. They'd retained and achieved very, very high medication adherence, indicating a strong prevention impact. And it's just better to go to your pharmacy and get this done. It'd be probably quicker, and it's a little bit more community oriented than what we tend to have in an academic center. So I think these community pharmacies that do have a PrEP-based clinic, and especially those that could be placed in predominantly Latino neighborhoods, have the potential to demonstrate that working under agreements with public health departments can allow pharmacists to handle the counseling, the insurance, or even assist with paperwork, appointment scheduling, making PrEP initiation faster and less burdensome for individuals. And I think more broadly, interprofessional protocols that have very clear referral pathways, shared lab and documentation systems, and regular check-ins between physicians and pharmacists, they have the potential to be associated with improved accessibility, patient satisfaction, and most importantly, to remain adherent and remain persistently on PrEP. And again, this vision of that I have, that if we go to the pharmacy to get our vaccines, maybe one day we go to the pharmacy to get our injectable PrEPs as well.
Amazing. Great, great stories to share that are collaborative and how we can partner together to improve our communities to help with the HIV prevention. We're coming to our end. We do have one more question I really want to get to from Jorge, if we can answer real quick. Equity in care and access is imperative for prevention and positive results. Is PrEP and PEP covered by Medicaid, or we still depend on community financial care? I would like to take that real quick. That'll be our
Well, I
last
mean,
question.
yeah, Dr. Cobb, do you have anything on that or?
I mean, I've seen oral prep, coverage, not an issue for like Medicaid. Not so much on the injectable side and whatnot. But definitely oral prep and even PEP. I've seen it
Yeah,
cover no issues with Medicaid.
agreed. In Louisiana, PrEP, just generic PrEP, is covered. Injectables are a little bit more difficult. And PEP, non-occupational post-exposure prophylaxis, um, can sometimes be a little tricky. But I'm a big believer of where there's a will, there's a way. As long as you have somebody who can navigate the system and understands how the system works, these will typically be covered as well. Not
Awesome.
without some obstacles, but if you can plow through them, they are navigable.
Love it. Well, there's a will, there's a way. So amazing. And I want to again thank you again to our speakers, Dr. Derry, Dr. Cobb, for sharing your time, your insights, your deep commitment to improving HIV prevention. It's such an important conversation as we work to end the HIV epidemic. Collaboration between physicians and pharmacists is essential in ensuring that all patients, especially those in Spanish-speaking communities and underserved communities, receive the care, education, and support they need. So before we close, I want to highlight a few important resources and next steps. As a reminder, please allow up to 1 week to receive information on how to claim your CME credits for physicians, pharmacists, and pharmacy technicians. You'll receive an information via an email blast in a week. Um, we also value your opinion, so please take a moment to share your feedback so we can improve future webinars. Simply scan the QR code or click the link in the chat box to complete the short survey. And thank you so much for joining this wonderful webinar. I also want to provide some resources. I want to put you some trusted tools and information from the CDC's Let's Stop HIV Together campaign. We encourage you to explore and share those materials with your networks, whether you're in public health, education, or advocacy. They're free and ready to use. So upcoming virtual events, we're hoping stay engaged with us on February 25th at 2 p.m. We have a town hall discussion discussing the importance of vaccination across every stage of life during respiratory virus season. And I saw in the chat we've just added the survey as well. So we have added some of our resources in the chat if you missed the slide QR codes. We're also encouraged to follow NHMA on Instagram, LinkedIn, Facebook, and Threads to stay updated on future events and initiatives. You can access downloadable resources and more at hispanichealth.info, our bilingual health education hub. Great resource. And if you're not a member, become a member of NHMA member today. Well, we invite you to join NHMA Network, whether you're a provider, advocate, student, or community leader. There's a place for you here. So definitely scan that QR code. We're putting all the links to be an NHMA member today. And so before we close, I want to highlight a valuable resource that NHMA offers. It's our job board. Whether you're seeking to your next career move or looking to recruit top talent, this platform connects job seekers with over 400 active employers and features more than 13,500 job postings. For employers, its providers access to over 19,000 searchable resumes and more than 3 million total profile views. Simply scan the QR code on your screen or visit our website to explore opportunities and connect with others in our network. So I want to thank everyone again for joining us today. Thank you to our speakers as well. Remember, we're stronger together against HIV. So everyone, have a wonderful day. Thank you, Dr. Derry. Thank you, Dr. Cobb. And thank you, NHMA, for putting this webinar together. And have a wonderful rest of the week.
Thank you.